Good evening, everyone. I warmly welcome you to our CellTalk webinar. In today's session, Divya Lakshmi will be presenting the research prognostic factors associated with survival in patients with diffuse astrocytoma. Our speaker Divya Lakshmi is a clinical content writer at Renix Life Sciences. She is responsible for writing scientific content on healthcare related topics. She also focuses on writing scientific white papers and review articles focusing on various fields of medicine and healthcare with the main focus on oncology, neurology, and immunology. Divya Lakshmi has a master's degree in dental surgery from the Rajiv Gandhi Institute of Health Sciences. Before joining Renix, she also worked as associate professor at D.A. Pandu Memorial, RV Dental College and Hospital, Bangalore, India. At Renix, she has attained operational as well as scientific writing experiences. So without further delay, I would like to call upon Divya to take over the session. Over to you, Divya.
Thank you, Yogita, for a good introduction. So, as Yogita said, my topic for today is prognostic factors associated with survival in patients with diffuse astrocytoma. Now, this article is mainly related to the topic astrocytoma, which is brain tumor, and it is from the journal Frontiers in Surgery with an impact factor of 2.568, and it's been published in the year 2021. And as per this article, this research has impact on multiple tumors like astrocytoma and glioblastoma. Coming to the brief introduction, these astrocytomas are the common primary tumors of the central nervous system, and as the name itself suggests, they are the arise from the astrocytes, which are the star-shaped cells, and the main function being the supportive function in the brain. Now, these astrocytomas diagnosis is mainly based on the histopathological criteria defined by the WHO, which grades these tumors into grade 1, 2, and 3 and 4. And here, presently, this article is based on diffuse astrocytomas, which are grade 2 astrocytomas. And our focus for today would be on diffuse astrocytomas. Now, what are these diffuse astrocytomas? They are very slow-growing and infiltrating tumors with ill-defined borders, and they comprise of usually 10 to 15% of all astrocytic brain tumors. And there are various types of diffuse astrocytomas, which are the fibrillary type, the protoplasmic variants, and the gemistocytic variants. And also the clinical symptoms which are associated with these tumors, they depend on the location of the tumor in the various parts of the brain. And one more very important point here is they have a relatively worse prognosis as compared to other histological variants, which is mainly because of the high recurrence rate, because of which is due to the infiltration of the brain tissue, and also it has an inherent malignant potential to transform into high-grade astrocytomas. These high-grade astrocytomas are otherwise known as the glioblastomas. Now, the challenges the authors have suggested in this study is the histopathological diagnosis of diffuse astrocytoma itself is challenging because of the pronounced heterogeneity, and also the tumor characteristics and the factors which are associated with the prognosis of these tumors. They are inadequately understood, and therefore identifying the various factors which are associated with the prognosis and the survival rate in diffuse astrocytoma patients was very much necessary, and that is what why the authors have gone into this research study. The main objective of this research was to investigate the clinico-pathological characteristics of diffuse astrocytomas and also to delineate the factors which influence the survival rate of the diffuse astrocytoma patients. The methodology which was being followed in this research is it was a population-based, mainly a retrospective cohort study. The data was extracted from the surveillance epidemiology and end results database, which was documented from 1973 to 2017. So in this retrospective study, about 799 patients were diagnosed with primary tumor as diffuse astrocytoma were identified, and this diagnosis was based according to the International Classification of Diseases for Oncology. The demographic features as well as the clinico-pathological characteristics of the patients were also collected, and the various variables like the age of the patient at the diagnosis, the race, sex, the marital status, the site of the primary tumor, the histological type, the size of the tumor, surgical treatment, the survival duration, as well as the survival status were all collected in this study. The primary tumor site was again subcategorized into 5 distinct categories, which is based on the various parts, location of the tumor in various parts of the brain, like the cerebrum, cerebellum, the brainstem, the spinal cord, and others. And patients with any unclear information on any of the collected variables were excluded from this study. The various analyses which were used in the methodology were the cancer-specific survival of the patients was stratified by each of the factors, and it was delineated by the Kaplan-Meier curve, and also the correlation between the clinico-pathological factors and the cancer-specific survival was analyzed using the Cox proportional hazards model, which included the univariate analysis as well as the multivariate Cox analysis. And for each of the patients, the significant prognostic factors were later plotted into the normogram calculator to get a predicted survival rate of that is 5-year and 10-year survival rate. And to evaluate the accuracy of the normogram, the C index and the receiver operating characteristic curve were utilized, and our software version 3.5.0 was used for the statistical analysis. Now, coming to the results of this study, and this table one, it mainly shows the total number of patients followed by the age, and then the sex, the number of patients where male was predominant. Race, again here the white was more predominant. Marital status, most of the patients were married. And when we see the primary site, cerebrum was the most common site of the location of the primary tumor, and the fibrillary variant, histological variant was predominant. And also surgery patients who have undergone surgery was more in this present study. And here is a picture that shows the various parts of the brain, which suggests that the primary site of the tumor was more in the cerebrum part. So as mentioned in the table 1, the incidence of the total 799 patients were tabulated, and the Kaplan-Meier analysis showed that the age at the diagnosis, marital status, primary site of the tumor size were all associated with the cancer-specific survival, whereas race and sex were not associated with the cancer-specific survival. Now, this is a table which shows the Cox proportional hazard analysis, both the univariate and the multivariate analysis, where the clinical characteristics of the patient compared with the cancer-specific survival rate. And as shown in the table 2, the results were that the age, marital status, primary tumor size, and surgery were all statistically significant with the cancer-specific survival. And also the age, the primary tumor site, and the size of the tumor as well as surgery, they were independent prognostic factors for diffuse astrocytoma. And also surgery was a protective factor, whereas old age, larger size of the tumor, and tumors which are located in the brain stem part of the brain were considered as the harmful factors for patients with diffuse astrocytoma. Now, this is the nomogram picture which was predicted to calculate the 5-year and the 10-year survival rate of the diffuse astrocytoma patients compared with the other clinical characteristics. And here, the nomogram showed that the overall 5-year and 10-year survival rate was 49.4 and 37.6% respectively. And the cancer-specific survival of 5-year and 10-year survival rate was 51.8 and 40.5% respectively. And also, the C index and the area under the curve ranged from 0.5 to 1. And this higher C index value or the area under the curve indicated that it was a better prognostic model. Coming to the discussion, the reports are very scarce regarding the detailed clinico-pathological characteristics of diffuse astrocytoma in literature, and also epidemiological characteristics and various factors which influence the prognosis of diffuse astrocytomas also are very unclear. And the authors have also reported that this present study is the largest one to depict the clinico-pathological characteristics of diffuse astrocytoma and also describe various factors which influence the survival. Coming to the various clinical pathological characters, we'll start with the age. Now, according to previous literature, it was suggested that the mean age at diagnosis was 45.7 years, whereas in this present study, the average age was around 41.9, and thus there was not much of a variation. And this disease mostly occurs in very young age, and thus it increases the economic and social burden for the entire family also. And age was definitely identified as a significant prognostic factor for survival of diffuse astrocytoma patients in the present study. And it was also reported by the authors that older patients had a much poor prognosis, and this was also reported in various studies in literature. The race and marital status, in accordance with the previous studies, it was demonstrated in the present study that whites were predominantly affected, and more than half of the patients had married. And also, the previous study reported that the diffuse astrocytoma cases were more prevalent among men than in women, and the male to female ratio was in the present study was slightly higher when compared to literature. Coming to the survival rate, the previous study has reported that 5 to 10 year survival rates were 48 and 36% respectively, whereas in the present study it was 49.4 and 37.6%. And the authors have also reported that surprisingly the tumor size also affected the survival, and the tumor size two optimal cutoff values of 25 mm and 44 mm were given to distinguish between the good, moderate, and poor survival. And regarding the primary tumor site, in the present study, the most common site was the cerebrum. And the authors have also reported the effect of the primary tumor site on the survival of diffuse astrocytoma patients. And diffuse astrocytomas in the brain stem had the worst survival rate when compared to other sites. And this could be because of the possible interpretation that brainstem plays an important role in the regulation of cardiac as well as the respiratory function. And thus, tumors in the brainstem, they are more likely to affect the heart rate and breathing, and thus it may lead to lower survival rates. And also in this study, the nomogram, which predicted the cancer specific survival of diffuse astrocytoma patients on a large population from the same database was constructed. And here is the salient features of the nomogram, which is an essential tool of modern medical decision making. And because it is a graphical demonstration of the statistical prediction model, which generates the survival probability of the specific outcome, the clinicians can easily figure out the prognosis of the patients by using this nomogram. This also assists in patient counseling as well as planning an individualized treatment approach. And also these nomograms are specifically worthy for clinicians in order to solve the complex diseases where they don't have any definite clinical guidelines. As other studies, this study also had some limitations. That is, diffuse astrocytoma can be defined based on the histological as well as molecular characteristics, whereas the SEER database did not have any relevant molecular information, which is one of the drawbacks. And also any information about radiotherapy or other forms of therapy other than surgery was lacking. So this also plays, and where other therapies also play an important role in the survival of these patients. And finally, because this was a retrospective study, the missing data and selection bias was inevitable because of the study design. Coming to the conclusion, the authors proposed that the present study is the largest one to date to investigate the clinico-pathological characteristics and survival of patients with diffuse astrocytomas. And they concluded that age, primary tumor size, the tumor size, and surgery were all associated with the survival of patients with diffuse astrocytoma. And thus, these outcomes may contribute to further management of diffuse astrocytoma patients. The impact of this research study is it may help in systematic treatment planning and predict the prognosis and better treatment outcomes. Also, to plan a personalized or individualistic approach to the management of diffuse astrocytoma patients. And finally, the survival rate of the patients. And all the above factors will in turn definitely impact the quality of life of the diffuse astrocytoma patients. Thank you one and all for your patient hearing.
Thank you so much, Divya, for this enlightening and informative talk. Now I open the floor to the audience. Vijay has a question. Why molecular features were not considered for survival analysis, as molecular features predict distinct prognosis in glioma subtypes?
Yeah, definitely. That is the main limitation of this study. The SEER database, because it's a retrospective study and the data was collected from the SEER database, they didn't have the details of the molecular characteristics. That's what has been mentioned in the article. So that is the main drawback of the study. It was only the histological details they had.
Okay, I have a question. What is the meaning of C index?
C index is part of the nomogram analysis, where the plotting, the graphs or graphical representation is plotted using the points. So that's what I understood.
Okay, thank you, Divya, for answering this question. Next question is from Nupur. Does a higher value of primary tumor size mean that the patient is at a higher stage of the disease?
The size of the tumor definitely may not have the correlation with the higher stage or higher grade of the disease. It could be just that the bigger the size or the higher the size of the tumor, it would be more closer to the vital structures or the surrounding vital structures based on the anatomy of the tooth. And also that may help in the surgical treatment where they need to plan the resection of the borders. So I don't think it is related to the higher grade or stage of the tumor.
Hope it clarifies your doubt, Nupur. Actually, I have another question. Are there any prognostic factors that affect the survival rate in astrocytoma patients other than the factors considered in this study?
I think here only the clinico-pathological characteristics are considered, and they have not gone into the molecular features or the biomarkers or the genetic criteria, which is again a different, completely different perspective. It gives a different perspective to the studies or to the tumors. And I think they definitely need to consider all the factors and not only the clinical or pathological.
Thank you, Divya, for answering those questions. Are there any questions from the audience? I see no further questions coming from the audience. So again, I want to thank Divya for the excellent presentation. I'm sure all of us can have a takeaway from this. Before we conclude this webinar, I would like to inform everyone that our next presentation will be on 15th Feb 2023, and Bharti will be presenting research titled Expression of CD133 Cancer Stem Cell Marker in IDH mutant and IDH wild type isocitrate dehydrogenase astrocytoma. I would like to thank you all for your time and kind attention today. Thank you all for being here. Hope to see you all at the upcoming presentation. Thank you so much.